I am Shahram Oveisgharan from Roche Alzheimer's Disease Center in Chicago. Our work is about motor manifestations of latency, which is an abbreviation for limbic-predominant age-related TDP-43 encephalopathy neuropathologic changes. Latency is common and is a major contributor to cognitive decline and Alzheimer's dementia in older adults. Few studies have examined other manifestations of latency beyond cognitive impairment. Prior studies showed that brain pathologies like AD were associated with faster motor decline, so we examined if latency was associated with faster motor decline in older adults. To accomplish this objective, we examined older adults who were enrolled in one of two longitudinal clinical pathological studies of aging, the Religious Orders Study, ROS, and the Roche Memory and Aging Project, which is MAP. In ROS and MAP, participants are older adults with down dementia who consent for annual clinical exam and brain donation at the time of death. Postmortem pathological assessment included latency and 8 other AD, ADRD pathological indices. And the annual clinical exam included motor performances that were grip strengths and pinch strengths that we summarize in this study as hand strengths. Dexterity, which is a summary measure of finger tapping and the Purdue pegboard test. Gait function, which was derived from walking 8 feet and turning 360 degrees. Respiratory muscle strength, which is an average of inspiratory and expiratory muscle strengths. And Parkinsonism score. To drive Parkinsonism scores, trained nurses examine participants for the presence of Parkinsonian signs, which are bradykinesia, tremor, rigidity, and Parkinsonian gait. They used United Parkinson Disease Rating Scale or UPDRS scale, and we use these the items of UPDRS to calculate Parkinsonism score. We use linear mixed effects models to examine association of latency with longitudinal changes of motor performances. Average age at death was 90 years old, 70% were women. Advanced stages of latency was present in 500 participants, about 1/3 of all participants. And participants were followed for an average 7 years before death. Latency was associated with faster rate of decline in respiratory muscle strength and a lower level of respiratory muscle strength before death. For the effect size, latency was associated with 43% faster rate of respiratory muscle strength decline in an average 90-year-old woman. Also, latency explained 4% of the variance of rate of respiratory muscle strength decline in our participants. Examining the other 4 motor performances, latency was also associated with hand strength decline, with faster rate of hand strength decline and a lower level of hand strength prior to death. These associations were also, they also persisted after controlling for other brain pathologies, the same as association of latency with respiratory muscle strength. However, the association of latency with hand strength decline was weaker than the association with respiratory muscle strength decline. Because, for example, in an average 90-year-old woman, latency was associated with only 18% faster rate of hand strength decline. And latency explained 3% of the variance of the rate of hand strength decline in our participants. Examining the 3 other motor performances, latency was associated with faster rate of dexterity and gain function decline and faster rate of Parkinsonism progression. However, these 3 associations were weak because they did not persist after controlling for other brain pathologies, or latency did not contribute to explaining variance in the rate of decline. The conclusion was that latency has other manifestations beyond cognitive impairment, which is motor impairment is one of them. And specifically, latency was associated with weak respiration and weak hand strength. I want to thank other faculties at Roche Alzheimer's Disease Center and our collaborators in other centers, and also the staff of our ADC that they help us in doing this research. and also our studies participants. Thank you for your attention.